and Murli as a chairman will manage the show. I request all those who are really interested in the academic excellence and research program, please join for the KCOG convocation at Davangere. It's over to Murli to continue the program. Thank you, Murli, for giving this opportunity.
Yeah. Thank you, sir. It is under your patronage that KCOG is doing very well, and you supported this idea of KCOG as well as the WeCare program, and then now the Cpap program. As you correctly pointed out, we wanted a single person to go into the depths of management, and we wanted all the clinicians to participate in question and answer session and clarify the doubts. We have touched upon different topics in this particular series, and today's topic is a very vexed problem of unexplained infertility. Infertility itself is a problem, but unexplained infertility becomes that much more difficult. And to tackle this, I thought no better person than Dr. Jayakrishnan, because I have been in close touch with him last so many years, more than 25 years, I think. And then he's been doing excellent conferences called Advances. And it used to be a treat for me to go there year after year. Unfortunately, last 2 years, we could not conduct these conferences. What I noticed in those conferences was that very high level, in-depth discussion of infertility topics, laparoscope, endoscopic topics, and all that. So, and he would always have a, excellent speaker from abroad. And today, I wanted to have his in-depth knowledge. May I have his CV, please, to formally introduce him? So, apart from being my friend, he actually, that's not the right introduction to him. The right introduction is he's the director and chief consultant of reproductive medicine in KJK Hospital, Trivandrum. 12 years experience in medical college and 24 years experience in private setup. More than 36 years experience in treating subfertile subjects. Performed more than 13,800 endoscopic procedures in last 21 years, which speaks for itself. And more than 5,250 cycles in ART IVF-XC. So I am sure you will all agree with me, he's the right person to deal with this topic today. 35 publications in national journals and 12 publications in international journals. Winner of RKK Thampan Award 1983 of All Kerala COG. Oxy Korean Award in 1996 at ASCOG Pune. Trained more than 245 trainees in laparoscopy and hysteroscopy over the last 21 years. Many of our own Manipal students, after passing MS, they have gone and got trained there and they have worked there. Trained more than, involved in 2 international trials, Palo study and MST study, contributed chapters in 17 books. Yes, Practical Insights into Infertility Management was his first book, and then came Insights into Infertility Management, second edition, Updates on Infertility Management, Biopic in Malayalam, and then Biopic in English. So totally 12 publications in international journals and 35 in index journals. Over to you, Jayakrishnan.
Thank you, Dr. Murli, for the kind invitation. First of all, I'd like to thank the Karnataka College of Obstetricians and Gynecologists, the chairperson, Dr. M.G. Hiramath, and the secretary, Manjula, and the KSOG also for the kind invitation, and the convener, Dr. Muralidhar Pai, for inviting me. And I thought this is a topic close to my heart, and I would like to share something regarding unexplained infertility.
I request all to mute their audio, except the speaker.
Yeah, hope the screen is visible for you.
Yes, sir.
I'll just put it in the slide mode. So I thought I would take you through, the audio is clear and the slide is also visible. So I thought next 30 to 40 minutes, I would take you through the unexplained infertility, the management options, and most important thing, I will take you through the evidence-based guidelines and my experience also incorporated into that. Unexplained infertility, common problem, remains a diagnosis of exclusion. So you have to exclude a lot of conditions before you say that it is a case of unexplained infertility. The diagnosis of unexplained infertility the infertility can be said to be unexplained. The woman has normal ovulatory function, semen analysis is normal, and tubal patency has been established by hysterosalpingography or laparoscopy. So these are the three criteria. Then everything is normal, then you don't have a reason for that. You call it as an unexplained infertility. Coming to the incidence of unexplained infertility, 30% of the patients after these investigations are diagnosed as unexplained infertility after a standard evaluation. So these three tests are the standard evaluation and everything is normal. Still the patient is not conceiving. You call it, it could be an unexplained infertility. And the factors which may contribute to the etiology of unexplained infertility could be, after you've done all these evaluations, still you don't find a reason. The factors could be subtle reproductive abnormalities. Subtle reproductive abnormalities could be Mullerian anomalies. It could be endocrine anomalies, which you are not evaluated. Routinely, we look at the thyroid and the prolactin also. It could be genetic problems associated with this. It could be immunological disorders. If you have done a sonosalpingogram or a hysterosalpingogram, you cannot diagnose minimal or mild endometriosis. So unless you do a laparoscopy, minimal and mild endometriosis is missed by sonosalpingogram and hysterosalpingography. Or it could be a compromised ovarian and natural fecundability that may be less. As age increases, everyone knows that the fecundability comes down. So it could be an age-related problem which compromises the ovarian function and natural chances of conception. So these are the things you have to keep in mind. After doing all these three tests, still it is unexplained. I'll go directly into the management options. Management options varies on various factors. The most important thing, whether the woman is aged more than 35 years or less than 35 years, duration of infertility. If it's a short duration, the prognosis is good. Suppose you find that the duration is prolonged, you find that the management options vary, and you have to take into consideration the couple's preference. You can't tell the patient you go for IUI, you go for IVF and things like that. The most important thing a clinician should find out is what the patient wants, what the couple wants. Previously, we used to say what the women wants. Now you have to find out what do they want actually. So couple's preference always should be given importance, and you should look at your healthcare setting. You should look at your healthcare setting means you have to find out whether your setting has got facility for IUI, whether you have facility for IVF. There are some uncommon causes for infertility. We routinely look at the thyroid disorders, hyper and hypothyroidism, even though the NICE guidelines tells you may not be needed, but we look at the thyroid disorders, hyper and hypo. Unless you look, you're not going to identify them. We look at hyperprolactinemia. We don't look routinely for Cushing's unless you have evidence clinically, or adrenal hyperplasia with evidence of hirsutism and clitoromegaly. Apart from endocrine, it could be genetic, a wide range of chromosomal anomalies, could be a single gene disorder, and phenotypes with multifactorial inheritance in both males and females. So you may have to look into the multifactorial inheritance in both males and females. The third cause could be immunological. The most common is an autoimmune disease like autoimmune thyroiditis. It could be antiphospholipid syndrome. It could be vasculitis due secondary to diabetes. It could be systemic lupus erythematosus. Serum autoantibodies has to be checked. The antiphospholipid antibody, the antithyroid antibodies, and the anti-nuclear antibodies may be directly associated with infertility, but they are very rare and commonly associated with recurrent pregnancy losses. So you don't have to spread the investigation to all of these. As and when the clinical findings are suggested, it could be hypo or hyper, or it could be hyperprolactinemia, could be genetic, or could be immunological. We look at the antiphospholipid antibodies, antithyroid antibodies, and also ANA, which helps you to diagnose immunological causes for infertility. But mind, these immunological autoimmune diseases are commonly seen with recurrent pregnancy losses. One thing, what about minimal and mild endometriosis? If you have done a sonosalpingography or hysterosalpingography for tubal patency, instead of diagnostic laparoscopy, in such cases, you can miss minimal and mild endometriosis. We have to be very cautious and looking at the pouch of Douglas, the brown spots. It could be sometimes, always need not be brown or reddish spots, could be avascular also. The lesions just looking like a scar tissue in the retroovarian area, the broad ligament, pouch of Douglas, the anterior UV fold, the posterior UV fold. All these areas should be closely examined because various studies, especially the Endocan study, has shown that if you diagnose minimal and mild endometriosis, if you coagulate the implants, you find that the fertility and the fecundability increases, and the chances of the woman conceiving in the next 36 months is quite high enough. So if you're not in the habit of closely looking into the pouch of Douglas, it could be what you call a cherry red spot, it could be a vascular spot, and sometimes you find there are white patches in the retroovarian, broad ligament, pouch of Douglas. Very carefully, you should convince that patient that you take a biopsy, send it for histopathology, and prove that it is endometriosis. And along with that, you do a coagulation of the implants, and you find that the chances of conceiving is much higher in this group of patients in the next 2 to 3 years. Now comes to maternal age. Maternal age plays an important factor. We all know when the woman is more than 35 years, the ovarian reserve comes down and the chances of conception diminish with advanced age. Especially when the woman is more than 35 years, you don't have to play with the woman. You may have to go for an active line of management. Suppose you have a young female with unexplained infertility, less than 30 years, need not be 25 years all the while, less than 30 years, expectant line can be managed. Expectant line of management will be you can observe and you can treat the patient for another 6 months or maximum a year before she conceives. You have to take into consideration the duration of infertility also. When the duration is less than 3 years, you find the prognosis is good enough. Suppose you're dealing with an unexplained infertility more than 9 years, 10 years, 15 years. These are not the patients for an expectant line of management. Definitely, when the patient comes to you with advanced stage, more than 35 years, certainly you have to look into the ovarian reserve, the antral follicle count, the AMH, and the FSH serves as a screening test. And especially you have to go for active line of management. And I would say, can you please mute your audios? Please mute your audio. I would say that evaluation typically, before you diagnose as an unexplained infertility, At least there should be one patent fallopian tube, documentation of ovulation in the female partner, and semen analysis with adequate number of motile sperms. So this is a basic criteria for diagnosing unexplained infertility. And unexplained infertility is a diagnosis of exclusion. And coming to the management options for unexplained infertility, I would take you through expectant line of management. In which group of patients you go for expectant line of management? What is the role of ovulogens, especially clomiphene citrate, letrozole, and gonadotrophins? What is the role of superovulation or ovarian stimulation with intrauterine insemination? Which group of patients you can take them for IUI? And which group of patients are ideal candidates for IVF as well as intracytoplasmic? So see, these are the management options. Could be expectant, could be ovulation induction. And now the third one is IUI with superovulation. And the fourth one is IVF or ICSI procedure. Coming to expectant line of management, expectant line of management plays an important role, especially you find in periphery there are limited resource settings. You will not always have IVF settings in the periphery, and especially when the woman is I would put less than 30 years of age, and the period of infertility is short. It is the first line of treatment. So woman less than 30 years of age, and if he's nearing 35, that is the time you have to go for an active line of management, no expectant line of management. Because average cycle fecundity, the probability of having a live birth in a menstrual cycle is 1.3 to 4.1%. So the couple should be advised to have regular contact during the fertile period. Most of the couple don't know what is it fertile period and when the ovulation occurs. They sometimes believe that it is the first few days of the menstrual cycle the ovulation occurs. So you should evaluate whether the couple knows when the ovulation is happening and to have regular contact during the fertile period. It could be a week sometimes. One study showed that 60% of the couples with unexplained infertility of 3 years duration became pregnant within 3 years of expectant management, especially when the woman was 25 years of age, according to Guzik, Sullivan, and Adamson, and way back in 1998. So expectant line of management, keep it plays an important role. I would put it less than 30 years of age or relatively young, short period of married life, not for a long period of married life. And the studies have shown that they become pregnant within a couple of years. Whether you can go for intrauterine insemination in a natural cycle. This study by Siladitya Bhattacharya from Aberdeen in the UK, he had a randomized controlled trial of 580 couples with unexplained infertility. They had a mild male factor and they were randomized for 6 cycles of IUI. So it's a natural cycle, means ovulation induction drugs were not given. So he found out that doing IUI, not giving ovulation induction, they were not significantly more likely to achieve a live birth. When compared to expectant line of management, 23%, whereas you find that natural cycle with your clomiphene citrate expectant line of management, you have 23%. So natural cycle IUI is never recommended. You should never go for a natural cycle IUI. If at all you do IUI, we'll go to that those slides later. So recommendation is whenever you perform IUI, natural cycle IUI is less effective and no more effective than expectant management. So if at all you do IUI, you have to stimulate them with ovulogens. And I will come to the ovulogens which are recommended for doing IUI, the oral ovulogens as well as the gonadotrophins. What about clomiphene citrate and intercourse? Whether a woman comes to you with unexplained infertility, whether you can give clomiphene citrate. I would say the clomiphene citrate is the most misused drug in the periphery. I have seen a lot of periphery, maybe due to lack of the resource. People just give clomiphene citrate in a regularly ovulating woman. You do more harm than good whenever you give clomiphene in an ovulating woman, especially if you're not combining it with the IUI. So clomiphene citrate has got some adverse effects. It has got some negative effect on the endometrium. And also you find the mucus becomes scanty, and unnecessarily you're reducing the chance for conception. I usually tell to my fellows that whenever you have to give a tablet, give them folic acid. When they're trying to conceive, folic acid is a drug of choice which you have to give. Never give clomiphene for a normally ovulating woman just because your resource settings is not adequate enough to deal with IUI or IVF. Just give folic acid to this group of, because evidence shows that clomiphene citrate with timed intercourse is no more effective than expectant management. So you create more harm by giving clomiphene citrate. The mucus becomes scanty, the endometrium becomes thin, the chances of conception becomes less. So the recommendation is clomiphene citrate with timed intercourse as a treatment for unexplained infertility is no more effective than expectant line of management. Don't give clomiphene citrate empirically. That should be an indication. She should be an ovulation, or she should be going for IUI, or there should be a definite reason. A normally ovulating woman, you never give clomiphene citrate because it has got adverse effects on the endometrium as well as on the cervical mucus. This study by Hughes Collins found out clomiphene citrate for unexplained infertility. When you give clomiphene citrate, it is associated with one additional pregnancy with 40 cycles of clomiphene compared to no treatment. So these authors conducted this Cochrane review shows that more than 1,000 patients, 7 trials, showing no evidence of clomiphene citrate being more effective than no treatment or placebo. So giving placebo or expectant line is much better, and it's not doesn't show any improvement in the pregnancy, as well as it has more harmful effects. So the recommendation is not to use clomiphene citrate in unexplained infertility. What about aromatase inhibitors, particularly when you find that letrozole was out of market for banned for 2 years, so for more than a couple of years on 2 occasions, and whether you can give letrozole with timed intercourse in unexplained infertility. The evidence shows that it is not recommended to use letrozole with timed intercourse as a treatment for unexplained infertility, as it is no more effective than expectant. Doing an expectant management gives you the same result, and the strength of recommendation is moderate. So there is no purpose served in a woman who is naturally ovulating, who's come with unexplained infertility. You give letrozole and just send her back and wait for 2 cycles or 3 cycles. This study, aromatase inhibitors, letrozole, has been used extensively in unexplained infertility. Liu et al. In 2014 compared the use of letrozole with clomiphene citrate in unexplained infertility. It included 3 studies from Al-Fawzan, Badaway, and Ibrahim. A total of more than 1,700 women reporting on clinical pregnancy. Letrozole use was associated with pregnancy rate of 199 out of 809, that is 24.5% in randomized trials. Clomiphene citrate was associated pregnancy rate with slightly less, 201 out of the 967, that is 20.8%. But when you look at the statistically difference, it is not statistically significant. Not statistically significant. So both letrozole and as well as clomiphene has been used, but there was not much statistical difference in using of either these 2 drugs in unexplained infertility. When you look at the pregnancy rate, which was otherwise clomiphene was slightly less, 24 with letrozole, and the pregnancy rate was not much of a difference. And coming to ovarian stimulation, can you give ovarian stimulation? She has come with unexplained infertility. Why don't you give gonadotrophin stimulation? Gonadotrophin stimulation alone may offer benefit in the treatment of unexplained infertility, but the main problem associated with it is a high risk of multiple pregnancy, which has been reported by Glacia in 2000. In the past 2 decades, minimal published data concerning the use of gonadotrophin ovarian stimulation is there. So there is no RCT comparing ovarian stimulation with gonadotrophins and expectant line of management.
ಪ್ರಶಾಂತ್ ಬಂದ್ರು ಕಂಪ್ಯೂಟರ್ ಆನ್ ಮಾಡ್ಕೊಳ್ಳಿ ಮೇಡಮ್ ಹೇಳಿದ್ರು ಅಂದೆ ಬಂದಂತೆ ಪ್ರಶಾಂತ್ ಅಲ್ಲಿ ಇಲ್ಲ ಈಗ ಫೋನ್
Can you mute everybody, please?
So ovarian stimulation with gonadotrophins alone, there are no RCTs to say that it is offering a benefit of the treatment, but definitely it is associated with a high risk of multiple pregnancy, which you have to keep in mind. Now comes for the recommendation whether you can use gonadotrophin with timed intercourse. It is not recommended to use gonadotrophin with timed intercourse, the treatment of unexplained infertility. Studies have reported no difference in pregnancy outcomes compared to ovarian stimulation with oral agents. Quite to the contrary, higher pregnancy rates associated with a higher risk of multiple gestation pregnancy. The evidence is weak and the strength of recommendation is moderate. So you are adding more problems by creating multiple pregnancies, multiple gestation, and it is going to be problematic when the pregnancy continues. So do not give gonadotrophins with natural intercourse for unexplained infertility as a trial. This is an interesting study by Agarwal and Mittal, and it's a randomized prospective trial with timed intercourse in supraovulated cycles with clomiphene versus IUI. IUI versus timed intercourse, and the results were published in the Indian Journal way back in 2004. Strong evidence that clomiphene citrate with IUI is superior to expectant line of management. And a natural cycle IUI, you find when comparing to natural cycle IUI, you give clomiphene citrate and do IUI, you find that the pregnancy rates are quite good. And it is recommended to use clomiphene citrate, maybe in a dose of 100 milligram according to the body weight, with IUI in the treatment for unexplained infertility. And you find that the strength of evidence is A, and the recommendation is quite strong. So clomiphene citrate with IUI is recommended. Clomiphene citrate with natural intercourse is not recommended. So this is a difference you have to keep in mind. So comparing IUI with combination of either CC, letrozole, or low-dose gonadotrophins, the summary says that there is fair evidence that clomiphene citrate and conventional dose gonadotrophins are associated with higher pregnancy rate than expectant line of management. And there is good evidence that clomiphene citrate with conventional dose is 75 units, low dose is 50 units of gonadotrophins. So 75 units definitely associated increased risk of multiple gestation. And there is good evidence that clinical pregnancy rate and live birth rate are similar when comparing letrozole and low dose gonadotrophin, that is 150, that is 50 units of gonadotrophins when you use for IUI versus clomiphene citrate. You find that the pregnancy rate, live birth rate are similar when comparing letrozole and low dose gonadotrophins IUI versus clomiphene and low dose gonadotrophins with IUI. So always go for the low dose gonadotrophins IUI. In IUI cycle, you don't require 75 or 150 units. You require only 50 units of gonadotrophins, and you find that you get very good results. This is a recent article from Farwa, 2018, ovarian stimulation with oral agents and IUI. 101 women, randomized controlled trials, underwent 3 cycles of IUI with oral agents. Principally, it was clomiphene citrate, although 7 received letrozole. And 100 women received 3 months expectant line of management. The mean age was 34, duration was 3.6, And the cumulative pregnancy rate with oral agent IUI group was quite good, 31%. IUI 31%, it is nearing IVF. Normally we get 10% or 12%, and the live birth rate in the expectant group was around about 9%. So IUI group 31%, whereas live birth expectant group 9%. So focuses on ovarian stimulation with oral agents, especially clomiphene citrate or letrozole. Clomiphene citrate usually we give 100 milligram and letrozole 5 milligram, and you find that the results are much good, but we never get 30% and 31%. We get about 10 or 12%. So this is quite good according to this order oral agents for IUI. What about aromatase inhibitors and IUI? Strong evidence there is no difference the pregnancy rate, multiple gestation.
But none
Multiple gestation following letrozole. Letrozole usually favors monofollicular development. So you find that the pregnancy rate is comparable to clomiphene citrate with IUI. Both are superior to expectant line of management. So don't go, well, clomiphene as well as letrozole are superior to expectant management in natural cycle IUI. So never go for natural cycle IUI. Give them either clomiphene citrate or letrozole. And it is recommended that letrozole IUI can be considered as an alternative regime for couples with unexplained infertility. And data suggests similar efficacy when compared to clomiphene citrate. So always use letrozole or you use clomiphene citrate whenever you go for IUI procedures. And oh my God. So coming to low-dose gonadotropins, IUI has been used with low-dose gonadotropins when the gonadotropin is less than 150 units. So the summary treatment tells you whenever you go for low-dose gonadotropins, we have been using gonadotropins around 50 units or maximum 75 units. We never go more than 75 units. There is insufficient evidence that treatment with low-dose gonadotropins is associated with higher pregnancy rate compared to clomiphene or letrozole. So woman who already had clomiphene citrate 3 cycles and another couple of cycles with letrozole, when she comes to you, you can try with the low-dose gonadotropins, and I would recommend anything less than 75 units. Don't go up to 150 units. You find multiple follicles develop, chances of multiple pregnancy, ovarian hyperstimulation, and problems associated with it. This is the Amigos trial, the largest RCT, comparing clomiphene, IUI, letrozole with IUI, gonadotropin IUI, a multicentric assessment of multiple intrauterine gestation from ovarian stimulation. Amigos is a multicentric assessment of multiple intrauterine gestation from ovarian stimulation. Trial compared clomiphene citrate, IUI, letrozole IUI, and gonadotropin IUI, Diamond et al., 2015. Amigos trial compared 300 women undergoing 4 cycles of clomiphene citrate IUI, starting with 100 milligram of clomiphene citrate, and 300 women who had 4 cycles of gonadotropin IUI, starting with 150 units of menopause. The pregnancy rate was excellent, 32% is as good as an IVF procedures. And you find the gonadotropin IUI, you find the pregnancy rate was 23%. The cumulative live birth was 32%. And with gonadotropin IUI and with clomiphene citrate, it was 23.3%. But look at the multiple gestation rate, quite high, 31% is unpardonable. Anything more than 3% or 4%. 31% multiple gestation with gonadotropin IUI. That all happens when your dose of gonadotropin goes up to 150 units with 24 twins and 10 triplets. What is the morbidity of this group of multiple gestations? And when you look at the clomiphene citrate IUI, you had 9.4% multiple gestation. That is also higher. Anything more than 4 or 5 is a higher range of multiple gestation. 8 twins and no triplets. So the problem with the higher doses of gonadotropin is going to be, even though you get good pregnancy rate, the morbidity to the women, the morbidity to the babies, the neonatal care and things should be taken into consideration. So it is not recommended to go more than 50 units or 75 units. Way back 2015, Diamond et al. But nowadays we never give more than 50 or 75 units. So the Amicus trial showed that the live birth rate was good with gonadotropin IUI, and it was 32%, whereas letrozole IUI, which was 18%, but higher incidence of 9 twin pregnancies, no triplets with letrozole, compared to 24 twins and 10 triplets, quite high. And you find the morbidity for the mother as well as for the babies, the ICU admissions and the things to follow up of these babies have to be taken into consideration. So higher doses of gonadotropins, higher live birth rate, and higher live birth rate is associated with increased multiple pregnancies. So Cochrane review 2016 by Weltman and Verhurst, the pooled data of 2016, more than 231 couples, gonadotropin IUI in one arm and 246 given gonadotropin alone, demonstrated that gonadotropin IUI with a higher pregnancy rate, the odds ratio is 1.69 compared to the gonadotropin alone. Multiple pregnancy rate reported 5 to 12%, anything more than 3-4% of 5 is high. And there were no difference in the multiple pregnancy rate between gonadotropin IUI and gonadotropins alone. So as you add gonadotropins, you see that the multiple pregnancy rate goes up high, and you find that you have to taper down the dose of the gonadotropins. So that is the thing you have to do. Don't have to go just by the literature search, go for 150 and 200 units for IUI. Maybe 50 or 75 units is quite good enough to bring down the multiple pregnancy rate, and you find the pregnancy rates, definitely they are quite higher when compared to the oral ovulation. So bring down the gonadotropin rate to 50 in case of polycystic ovarian syndrome, or in other cases, an unexplained infertility, you can go up to 75 units, and keep the follicles, the dominant follicles around 2 to 3, and cancel the cycle whenever more than 4 follicles are dominant enough. So whenever you find follicles are more than 4, the incidence of multiple pregnancy also starts. What about laparoscopic surgery in unexplained infertility? After doing all these things, whether you go for laparoscopic surgery, I would suggest that in absence and evidence of tubal or pelvic pathology, we do less invasive investigations. We do a pelvic ultrasound, we do a hysterosalpingogram, we do a hysterosonography, and find out whether the tubes are patent. But you're not looking into the pelvis. You are not looking into the mild and minimal endometriosis. And we have published a study way back. Can you just mute your audio? Laparoscopy is not warranted in a diagnosis. You don't have to go and do laparoscopy in all cases of infertility before going for IUI, nor it is needed to diagnose unexplained infertility. Unless you do laparoscopy, you're not going to diagnose minimal and mild endometriosis. And we have conducted a study where there was an absence of pelvic factor. We did either HSG or sonosalpingogram. We went for IUI for 3 cycles, 3 to 4 cycles. And whenever the patient didn't conceive after 3 or 4 cycles, we went for laparoscopy. And we could find pelvic lesions in 9 to 10% of the case. Recommendations concede that there may be a place for diagnostic laparoscopy, especially when the woman is more than 3 years of, has 3 years of infertility, no recognized abnormalities, because minimal, mild endometriosis, additions, and other things which are not picked up by ultrasound, you can pick it up by directly doing a laparoscopy. Younger age group, shorter period of married life, don't have to go for IVF, go for laparoscopy. And we had many patients going for laparoscopy after failed IUI. And maybe 3 to 4 cycles later, they go for laparoscopy, and we go for active line of management, and most of them do conceive within 6 months to 1 year after laparoscopy. So laparoscopic surgery definitely has a role, because you're not picking up minimal, mild or minimal additions using a hysterosonogram or sonosalpingography or hysterosalpingogram. And recommendation is, after doing this test, going for IUI, go for laparoscopy. The patient doesn't want to go for IVF immediately. Go for laparoscopy, and your pregnancy rate will be quite good. Coming to the last chapter on IVF and treatment paradigms. The current evidence does not support IVF as the first line of therapy for unexplained infertility. Over expectant line of management, you can go for expectant line 6 months, limited course of treatment, ovarian stimulation with IUI, provided the woman is less than 38 years of age. I would put, well, the age not a most important fact, I would put the antral follicle count and the AMH also within normal limits. And suppose you find the antral follicle count as well as the AMH is good, don't have to immediately rush for IVF. Go for the first line therapy, maybe expectant line for 6 months and a course of treatment of ovarian stimulation with IUI. Suppose a woman is more than 38 years of age, you find that there is a higher pregnancy rate and a shorter time to pregnancy. IUI you may have to do for 3 to 4 cycles, maybe 6 cycles sometimes. But when you go for IVF, there is a higher pregnancy rate and a shorter time for pregnancy. Woman more than 38 years, supplement it with antral follicle count as well as AMH study if you're going for IVF. And definitely you find that there's a higher pregnancy rate when you go for IVF, rather than wasting your time with ovarian stimulation and IUI treatments. The recommendations are unexplained infertility. Patients do undergo 3 to 4 cycles of ovarian stimulation and IUI with oral agents. And those are unsuccessful with oral agents, IUI, IVF is recommended rather than moving on to gonadotropins. Don't have to move from oral agent. They're fed up with IUI for 4 cycles and 6 cycles with ovarian stimulation and IUI. Don't again go for ovarian stimulation with gonadotropins and they lose the trust in you. Better go for IVF rather than ovarian stimulation and IUI with gonadotropins. So the recommendation is moderate and the strength of evidence is B. So this is a published data, controlled trials comparing gonadotropin IUI with IVF from 2000 to 2017. The number of subjects are quite high. Rain Dollar 2010, 503 subjects. After 3 cycles IUI, he got a pregnancy rate of 21%, whereas with IVF, he has got 52% of pregnancy rate. And here you find the more recent one, Nanti 2017, 207 subjects. After 3 cycles of IUI, 28%, 0.7%. And after IVF, almost similar, not much of a statistical significance. So he has got 3 cycles, IUI 28.7. After IVF, he had 33.1%. And you find that the pregnancy rates are quite comparable to the non-tubal factor infertility. So there is clear benefit that live birth rate following IVF scores over the other treatment options. So clear benefit that the live birth rate following IVF is quite high when compared to the other treatment options, especially IUI. To be honest, I would say in our setup, we hardly find any pregnancy rate more than 12 to 15% with IUI. So we go for IUI for maximum 3 to 4 cycles and almost most of the patients do have a course of oral agents. So we go for a low dose, gonadotropin IUI, and you find that scores slightly over the other group with the clomiphene or letrozole, because most of the patients do have a course of clomiphene or letrozole. And what additional we can offer them immediately you can't switch over to IVF in this group of patients. They want a course of another IUI. So you can think about the low dose FSH or HMG, and you find its course all over the oral ovulations. So the summary recommendations and future directions are: the best initial therapy is ovarian stimulation with IUI. You can use clomiphene or letrozole, equally effective. And after that, go for IVF for those who are unsuccessful. There's a pressing need for additional therapies to bridge the gap, but we don't have much of additional therapies to bridge the wide gap between ovarian stimulation, IUI, and oral medications with oral medications and IVF. So there is no intermediate therapy available. Further research is needed to improve the access to care, including ART treatments. So further research, whether you can bridge the gap. Most important thing you have to keep in mind, repeated IUIs and failures, you find reduce the emotional and physical burden. And you find the physical burden and emotional burden actually you find is increased. So if you can expedite treatment with IVF, you shorten the time of pregnancy, and you find that the emotional and physical burden is lessened in this group of patients, especially if you go for IVF. And we have seen patients going for IUI for 6 cycles or 12 cycles. To be honest, if you want to get IUI success, first 3 to 4 cycles, you will get an IVF, you will get an IUI pregnancy. Very rarely after the 6th cycle, you get a pregnancy, once in a while. But you may have to wait for another 40 cycles for that patient to get a pregnancy. And you find the emotional as well as physical burden is increased as the time goes on. So you have to reduce the burden, and you have to go for IVF. Whether IVF can be used as the first line, a patient comes with unexplained infertility, whether suddenly she's around 37 years of age, and whether you can go for IVF. Studies suggest, especially the study from Custers, Van Rumstein, the long-term outcome in couples with unexplained infertility. There is no benefit for immediate treatment with IVF. You can wait. You can go for expectant management for 3 to 4 months. Another 3 cycles, you can go for ovarian stimulation with IUI and wait as a first. You don't have to rush for IVF. So wait for about 6 months, and there is no benefit for immediate treatment with IVF. What about ICSI in unexplained infertility? It has been told that whenever you're doing IVF in unexplained infertility, you have a chance of a total fertilization failure, and failed fertilization occurs in 5 to 10% of the cases of IVF. So this was an RCT comparing the conventional IVF with ICSI in the non-male factor infertility. They have not found any benefit of adding ICSI as a routine. Bhattacharya and his group has not found any added benefit of adding ICSI as a routine for unexplained infertility in IVF centers going for ICSI, or dividing the oocytes, half IVF and half ICSI. They have not found any benefit. A systemic review and meta-analysis, more than 11 studies suggested that routine ICSI was effective in both increasing the fertilization and decreasing the incidence. So this is the most important thing. Total fertilization failure, which happens with IVF, occurs in 5 to 10% of the cases. If you go for IVF, sometimes you are doomed with a total fertilization failure. That is why people split the oocytes for half of the IVF and half of ICSI. But RCTs comparing have not found any benefit for adding ICSI. But if you are dealing with a patient with high chance for a total fertilization failure, I think ICSI is a must for unexplained infertility. You're not pardoned if you do ICSI in all embryos, and there's a if you do IVF in all embryos and there's a total fertilization failure, you can't do anything but to call her the next time. So recommendation from RBM Online 2019, there is insufficient evidence to recommend routine addition of ICSI in couples undergoing IVF to go for ICSI procedures. when they have unexplained infertility to increase the live birth. The main idea was to increase the live birth, and addition of ICSI may reduce the incidence of total fertilization failure. So with the history of definitely, but if you don't want to take a risk, you may have to go for ICSI. What about the UK guidelines? The UK guidelines have advised against gonadotrophin IUI. They prefer going for oral ovulogents like clomiphene citrate. Letrozole is not available in UK. And if it fails, they go for IVF. Because the risk of multiple pregnancy associated with gonadotrophin IUI is reduced definitely when you go for an elective single embryo transfer in IVF. So UK guidelines, they don't advise gonadotrophin IUI, but some people who recommend, especially if the person had all the resources exhausted, and you find you may have to go for this thing. Summary, I would say that the current evidence does not support IVF as the first line of therapy for IVF. Over expectant line for 6 months, limited course of treatment with ovarian stimulation IUI. Most important thing, woman less than 38 years of age, and I would add to that AMH and antral follicle count satisfactory. And there is good evidence when the woman is more than 38 years of age, you can associate a higher pregnancy rate and a shorter time for pregnancy as compared to a strategy consisting of ovarian stimulation and IUI treatments, either with oral medications or gonadotropins. So more than 38 years, you presume, or you have to confirm with an antral follicle count and AMH. And definitely when they are low enough, you have to proceed for IVF rather than going for IUI procedures. And the same thing is being repeated. Recommendation is couples unexplained, go for 3 to 4 cycles with ovarian stimulation with IUI. And those unsuccessful, recommendation is either you can try with gonadotrophins for 2 or 3 cycles, or you can go immediately for a IVF. So the risk also should be kept in mind, especially if the woman develops multiple follicles. You can have a GnRH analog trigger, and whenever you find that the follicles are more than 3 in number, you cancel the cycle. And less commonly, you see that hyperstimulation is associated with oral medications. But in the setting of IVF, you can go for a single embryo transfer. Most important thing, avoid overtreatment in a woman. Do no harm. That is a principle of any treatment. Avoid overtreatment is prevention of hyperstimulation, prevention of multiple pregnancies. Definitely, it is going to add to the morbidity of the woman. Definitely, you may have to take into consideration the risk consideration, especially when you are going for gonadotrophins in high doses. The woman is at high risk of multiple pregnancy and hyperstimulation. And the take-home message is a strategy of 3 cycles, clomiphene or letrozole IUI, followed by IVF, especially when you find a shorter time to pregnancy at a lower cost. And you find IVF is cost prohibitive for many couples, and there is a place for investigations, evaluation of the treatments to bridge the gap between the effectiveness and the low success rate. We find low success rate with oral ovulogents, 10%, 12%, 7%. Anything more than 15 is quite good enough. 15 to 20 should be your aim. If you get 10%, 7%, 6%, that is the what you call the low effectiveness of the. I usually tell my colleagues, normally a woman has got 1 follicle. If the woman has been given ovulogens and they still develops 1 follicle, that means your stimulation is not effective. So your stimulation should be, suppose you are given 100 milligrams, still only 1 follicle is developed. You may have to give 150 maximum dose of clomiphene citrate. Or sometimes you may have to give 5 milligram of letrozole instead of 2.5. So you find low success rate associated with ovarian stimulation and IUI with oral medications. You have to bridge the gap or change over to a low dose gonadotrophin IUI, or especially in some group of patients, you find a thin endometrium associated with clomiphene citrate. you may have to switch over to gonadotropins or letrozole and bridge the gap between this. So unanswered questions are there. Therapy should report adverse outcomes, especially ovarian hyperstimulation, multiple gestation, and the trial should be comparative, and additional RCTs should compare a sequence of treatments for unexplained infertility. One treatment strategy to other treatment strategy, and RCT should be done. And studies should be directed to treatment options of the male factor. Often you find the male factor is neglected. The male factor has to be evaluated in unexplained infertility. What about the motility? What about the DNA fragmentation? What about the smoking? The male factor plays an important role, is a neglected factor in unexplained infertility. Whenever you find motility is less, you have to look into the DNA fragmentation. You have to go for the sperm washing with a gradient method, separate the actively motile, the progressive motile sperm from the dead and non-motile. So it may be the male factor which is contributing to the male unexplained infertility. So use proper sperm preparation techniques and give antioxidants to this group of men and try for 3 to 4 cycles before you switch over to IVF. This is the famous Mullaperiyar river, the controversy between Kerala and beautiful Thekadi. You can see with the controversial river between sharing of the waters of the Mullaperiyar, and the references I have taken for this presentation is from the American Society NICE guidelines 2013 and the Canadian guidelines RBM Online 2009. So I thank you very much, Dr. Murli, for the kind invitation, and I would thank the Karnataka College of Obstetricians and Gynecology for giving me an opportunity to express my views and thoughts on unexplained infertility. So thank you very much.
Yeah, thank you. Thank you, Dr. Jayakrishnan. It was really, really elaborate, and you made it so clear using the 3 very, very important guidelines. Before I have my comments or questions, I would like to ask the question in the chat box. What is the course of low-dose gonadotropin 75 IU for ovarian stimulation? When to start? How many days to give? I remember in one of the conferences you gave almost 25 days.
Yeah, that's right. Usually low dose, we for PCO patients, we stick on to 50 units. There is no scope for 75 units for PCO patients. And sometimes you find that giving 50 units maximum, if you step up the dose to 75, you find multiple follicles to develop. And we have had pregnancies after giving 25 days, 27 days, or even 30 days of stimulation. So do not give up after 25 days or 7 days. If you increase the dose, the number of follicles will start increasing. So if you want follicles 2 or 3 in number, you maintain the 50 dose, and you find even with 25 days or 30 days, we had pregnancies with IUI. I think for PCO patients, you have to stick on that. For unexplained infertility, every 5 to 6 days, you can increase by 25 units. 75 units can be given, but we never go more than 75 units, because you find that whenever it goes beyond 75 units, multiple pregnancies, OHSS, and the problems arise.
Thank you. Many centers, especially in the West, they have now given up IUI in a way. They are, at least they are restricting IUI only for if there are, problems with deposition, that is either premature ejaculation or impotency and things like that. So many people believe that it is straight away IVF, though you have very nicely, clearly told it's not the first line. Believe that for unexplained infertility, especially, IUI is better because it can overcome many of the problems, of course, excluding the uterine one. So what's your opinion? Practically, coming out of the guidelines.
Yeah. Practically, the Indian scenario, you find that when the person, the couple comes to us, you can't jump into IVF because they have gone through the internet. I have seen many of my colleagues also going directly for IVF. I think in the Indian scenario where you find that the insurance not covering the IVF, I think it gives a very fair amount of success. You can't totally exclude IUI. because still you find many of the people can't afford IVF. They still depend upon IUI, and you get a fairly good around 15%, a maximum 20% with IUI. And I think it's worth giving a trial, especially when you find the insurance is not covering your IVF. So I still think in the Indian scenario, IUI is going to play an important role. I think we should stick on to with oral ovulations first. Patient already had oral ovulations and IUI. I think you have to move on to the IUI with gonadotropins. Don't go more than 75 units. PCO patients, 50 units. And patients with unexplained, 75 units should be a maximum, and you find you are in the safe zone. So I think that should be the dictum. Don't have to go directly for IVF, because that may be the ideal one, but most of the patients cannot afford. And affordability and thing is a big thing for the Indian scenario.
Yeah, well, that's true. And how many cycles maximum you would give IUI?
IUI, we give 3 to 4 cycles. We usually say in the first 3 cycles, the patient is going to conceive. It occurs in the first 3 to 4 cycles. Very rarely, if the patient persists, doctor, please go on for another 2 more cycles, we may go on. Otherwise, we have to stop it by 3 to 4. There is no point going beyond 6 cycles. You find the pregnancy rate just comes down quite a bit after 6 cycles. So there is no point in going beyond 6 cycles. I would prefer 3 to 4 cycles. It'll give you the maximum success rate. And more than that, you find you're wasting your time.
Before handing over the mic to today's chairman, Dr. M. J. Ramat sir, and I would just try to quickly read a couple of complimentary messages. Dr. Vidya Tobi says, excellent talk. Dr. Malini said, excellent talk again. And then Dr. Usharani says, very informative talk, sir. So over to you, Dr. M. J. Ramat sir.
Thank you. Thank you, Murli, for giving Jai Krishnan's valuable 45 minutes time and excellent literature review. Wonderfully, you have done literature review, sir. And regarding IUI, we all thought that IUI has no role in unexplained infertility, as Murli said. I think you have given us such a evidence that, and as you have also told in red letter, evidence doesn't support IVF as a first line. I think this is the biggest take-home message from you, sir. But I have got some questions because I am into IVF for the last 1 decade. Nowadays, I am fond of using long-term clomiphene citrate. Rather than 5 days, I am using it for 7 days. Letrozole also I am using rather than 5 days to 7 days. And letrozole I am using doubling dose. First day 2.5, second day 5, next day 7.5. I am finding that the results are little much better than that. What is your experience on this, sir?
This is for ovulation induction, IUI?
Ovulation, routine ovulation induction.
Basically, I have tried with 2.5 and 5 milligram. I have not gone beyond 5 milligram. And
no, 5 days, number of days, 5 days.
Number of days, I've gone only up to 5 days. I not
7 days.
Not 7 days. But definitely, you have got literature studies are given up to 10 days.
Yeah.
Giving bolus dose of letrozole. But practically, I don't have much experience at giving higher doses. More than 5 milligram. I'm
using this for 7 days. This is helping us when we combine the oral with the gonadotropin, which you have suggested. Half period oral, next half gonadotropin. For example, day 2 to day 9, give oral. From day 10, you start 75 IU of gonadotropin, and your growth rate will nicely improve. So the results I am finding much better combining. And for all unexplained infertility, I have never gone for natural cycle because the patient won't accept at all. If I do anything in the natural cycle, at least I have to do the superovulation by giving these oral or gonadotropin. That is number one. What is your experience of finding sexual dysfunction as a cause of unexplained infertility? I am a sexual medicine specialist, and I get at least once in 3 months one such case where they are married for 5 to 6 years and so many investigations are done. In fact, they don't have any knowledge of sexual at all, and proper intercourse is also not done. What is your opinion, sir?
Yeah, occasionally I find that the Kerala, what you call the patients are literate.
Yeah,
Occasionally we find that we all do a transvaginal ultrasound for evaluation of the follicular study.
yeah,
Occasionally we find that the female patient doesn't allow the probe to be inserted.
yes,
And on cross questioning alone, the patient will not come with a history of any coital problems or sexual problems. They have been married for 3 years or 4 years.
never had intercourse because of
And
vaginismus.
you find they have difficulty. May not be,
Yeah,
it could be a partial penetration, or it
Yes.
could be a difficulty. And often when you insert the probe, you find that she's struggling, or
Yeah.
she's making a huge rack and ruckus, and you find that you are diagnosing a sexual dysfunction also. So
Yeah.
I think the most important thing is to proper counsel the woman regarding the ovulation time and whether they are having a proper intercourse also, because once in a while you're caught with people who are not coming out with this history.
Yeah.
But on a clinical examination, by putting in a speculum or even a probe, sometimes the vaginal transvaginal probe, you pick up that she's having a sexual dysfunction and has to be corrected prior to this thing.
This we are finding more often in our rural women. 60% of the women in our North Karnataka, they are much unaware of the sexual functions. I think this is one of the common problem we are facing, sir. Suppose somebody has done a laparoscopy 3 years back, evaluation. Now they have branded this woman as a unexplained infertility. Do you want to repeat the laparoscopic evaluation or not?
I go with clinical evaluation and ultrasound and find that the uterus is mobile, there is no Boucher-Douglas tenderness or retroversion or fixed retroversion. And look at the patient's perspective also. If they are have an inclination for most of the patients do not want a repeat laparoscopy.
Yeah.
And suppose you have a clear-cut record saying that all these has been evaluated, no evidence of minimal mild endometriosis. But if the patient says that they're not going for an IVF, they would still like to undergo a repeat lab. Occasionally, only we go for a second laparoscopy in a patient who had already done a laparoscopy and underwent IUI for 3 cycles. Or more frequently, we have to take into consideration the age, the AMH, as well as antral follicle count, and take her for IVF.
Yeah. This is the last question. Do you do lab history evaluation for all IVF cases before you go for IVF, or you do IVF without doing lab history?
I think lab histro has gone. Previously, we used to do the hysteroscopy.
Okay.
Hysteroscopy is quite good enough, especially when one or maybe about 8 or 10% of the cases you miss some lesions. So we do a routine hysteroscopy.
Okay.
That is mainly to find out whether there is any problem in the passage of the catheter or any stenosis of the uterus. Evaluate the cavity. Even your routine ultrasound misses about 8 to 10% of the cases. But laparoscopy we never do as a routine in IVF cases.
Hysteroscopy is a must before going for
Hysteroscopy after the onset of the scratch trial. It's not for scratching we are doing.
Okay.
Previously we found that scratching was done prior to hysteroscopy. But hysteroscopy, after doing a routine pre-IVF hysteroscopy, we have found that the incidence of difficult transfers have come down.
Okay.
So you can evaluate the canal, you can evaluate the cavity, and as I told you, subtle lesions of the intrauterine lesions like intrauterine adhesions have been picked up by hysteroscopy directly looking at that. So we find additional benefit of hysteroscopy, and around 5 to 6% of the case, the things missed with the high resolution ultrasound are picked up, and you find things are much easier when you go for an embryo transfer. We don't do a hysteroscopy just for scratching alone.
Are you using sildenafil to improve the endometrial thickness in unexplained infertility?
We don't, of course, sildenafil usage may not. We give sildenafil not in unexplained when the endometrium is less than 7 millimeter, 25 to 50 milligram twice a day for 2 to 3 days. But commonly you find that not much of the improvement occurs, and you may have to switch over to gonadotropin in this group of patients, especially with endometrium is less than 7 millimeter. And I think either letrozole IUI or gonadotrophin IUI may be suggested in this group of patients.
Thank you very much, sir. It was just wonderful scientific session. So many doubts have been cleared, and you have excellently given the whole literature. The whole word literature has been provided to us. Definitely, I feel our practice will improve with transmission of your knowledge to our all Ksogians. Thank you very much. Namaste to all. Dr. Murli.
Yeah.
Durgadas is not there. You have to do the vote of thanks also.
Okay. So thank you very much. There are more complimentary
no
notes.
more questions.
No more questions. There are
Only
more complimentary notes
okay.
from many people. So first of all, on behalf of KSOG and KCOG and Cpap series, I extend wholehearted gratitude to Jai Krishnan, who readily agreed to engage our clinicians this evening. Thank you very much, Jai Krishnan.
Thank you.
I would like to thank our patron, Dr. M.G. Hiremat, who has never, I think, missed a single Ksoga or a KCOG meetings. In fact, we are having Jai Krishnan every week too, and every month we have 8 since last January. So, and he has attended all of them. So I also thank Dr. Our president, who could not be there today, and our secretary, Dr. Bharati. I don't see her here today, and our dean, Dr. Hema Divakar, and the secretary of KCOJ, Dr. Vidya Bhatt. And today's meeting was conducted by Dr. Manjula. I thank her for doing that. She's also been a sort of default MC. So she has been doing this job very meticulously, program after program. I thank her very much. And most importantly, I thank all the delegates that have logged in today and got benefited. So Dr. M.G. Hiremat said, I just gave less than a week notice for this particular program. For the next month program, I'm giving 1 month notice.
Yeah, thank you.
Actually,
thank you.
Dr. Jai Krishnan had confirmed this 15 days early. Somehow it missed from my mind to send you the name. Next month, December 7th, is Dr. Chinmayi Ratha. She's a fetal medicine specialist. She'll be talking on management after diagnosing an anomaly, what to do, because diagnosing anomaly is something which now most of the people, they can do it with a high resolution ultrasound. But what to do after that is the biggest dilemma. Which ones should be terminated, which one need not be terminated, is a big dilemma for most of the clinicians. And to enlighten that, she's going to be talking on December 7th, 7:30, Dr. Chinmayi Ratha. Thank you.
Murli. Announcing 1 month in advance. Yeah. Namaste to everybody. Once again, Happy Diwali. And all those who are participants are still there. Please make on your audio. We would like to see you and tell Happy Diwali.
Video, sir.
Videos. All of them. Let them start their videos. Nagratna madam is there. I can see her. Happy Diwali, madam.
Sir, Happy Diwali. Shivmurthy.
Thank you,
Shivmurthy sir. Happy Diwali.
Shivmurthy, Happy Diwali.
So happy Diwali to all of you, sir, to all KCOGians.
Yes. Thomas Kuriyuko sir, Shivmurthy, Kasturi Dodipat.
Happy Diwali, sir. Happy Diwali, sir.
Subhash Mudunur, Vidya Tobi madam. Happy Diwali.
Happy Diwali, sir.
Yamuna,
Happy Diwali.
Chandu.
Great,
Monica,
sir. Great event. Oh.
Mithun, Chandana.
Happy
Dr. Christy, Happy Diwali to everyone.
Yes.
Happy
Diwali, sir.
This Friday program is not there because of the festival. Next Friday we have got KCOG International Program. Dr. Hema Divakar will be conducting that program.
Yes, sir. We are there.
Yeah, once again, Happy Diwali. Namaste.
Thank you, one and all.
Once again,
thank you, sir. Happy Diwali.
Thank you. Really indebted to you, sir. Ellarigu Deepavaliya Subhashayagalu.
Good night, Shubhratri.
Good night.